All right, let's see if everything is perfect. All right. Okay, perfect. I think we are all set. Okay, let's get started with the fourth section of rapid review, and this system will cover on some of the interstitial lung disease, lung cancer, and some of the obstructive lung disease. Okay, so let's get started, guys, and this is our first question. Okay, elderly man is presenting to you with progressive exertional dyspnea and cough for 5 months. He's having history of recurrent pyelonephritis, peptic ulcer disease, and rheumatoid arthritis. He was started on methotrexate for rheumatoid arthritis, but he wasn't improved with his symptoms on methotrexate as well. On examination, the joint disease like rheumatoid arthritis is present. The chest X-ray is shown here. Which of the following explains the pulmonary symptoms in this patient? So, oops. What's your saying about this? Okay, first of all, tell me, this patient is having progressive dyspnea and you do the chest X-ray. Your chest X-ray is showing like this. You have a lot of interstitial markings like this, and you also see some of the fibrosis here. So what do you think the patient is having? If you just see the chest X-ray without like knowing any of the history, what do you think the patient is having? If you see a lot of reticulonodular opacities in the chest X-ray with some of the honeycombing, what do you think the diagnosis is? Okay, this shows fibrosis. Okay, fibrosis. This is fibrosis, and we also saw fibrosis as a component of interstitial lung disease when the patient have rheumatoid arthritis. Okay, there was a section that we were studying about interstitial lung disease, a type of restrictive lung disease, and rheumatoid arthritis is also one of the cause of interstitial lung disease where the patient can get lung fibrosis because of rheumatoid arthritis. Okay, so this is fibrosis. So like, do not get bogged down if the patient has history of rheumatoid arthritis. He was not improved on methotrexate. So this can be a possibility that patient is resistant to methotrexate if the patient has rheumatoid arthritis. So this patient was not improved on methotrexate. At the same time, the dyspnea is because of lung fibrosis. Okay, so rheumatoid arthritis patient can also get lung fibrosis, and this patient is having dyspnea because of pulmonary fibrosis, a type of restrictive lung disease. Okay, so this is interstitial lung disease or lung fibrosis because of rheumatoid arthritis. Now, this is very important. A patient of lung fibrosis is coming to you. Okay, first of all, we do the chest X-ray. Okay, like first of all, let's say somebody is coming to you with dyspnea. We do the chest X-ray, and you see some of the interstitial patterns like this. We order HRCT of that patient. All right, so we order HRCT of the patient. We also order ANA to rule out any autoimmune condition. We also order RA factor. Okay, and if the RA factor is positive, we can say, okay, this patient is having rheumatoid arthritis, like as a component of rheumatoid arthritis. If the patient is having RA factor negative, we call it seronegative rheumatoid arthritis induced interstitial lung disease. Okay, so it's not necessary that the patient will be always RA positive. Okay, the patient may be RA negative and the patient may have seronegative rheumatoid arthritis, and as a result of that, the patient might have interstitial lung disease. And one of the important other side effect of treatment of rheumatoid arthritis, if you start the patient on methotrexate, as a side effect of methotrexate also, the patient can have lung fibrosis. Okay, so this patient can have lung fibrosis because of side effect of methotrexate or because of the disease itself. Okay, so that's lung fibrosis. Okay, let's go to the next one. This should be easy. Let's say a 40-year-old man is complaining of dyspnea. The curve 1 is normal. Okay, this graph is showing pressure versus volume relationship. Okay, so curve 1 is normal. The curve 2 is showing the patient's curve of the pressure versus volume. So if I say you are comparing delta P by delta V, pressure versus volume, what do you get? What do you get if you compare delta P by delta V?
Compliance.
Any compliance? So this is not compliance actually, this is elastance. Okay, what is compliance then?
Okay,
Delta V by delta P.
Perfect. So compliance is delta V by delta P. Okay. So we have to check compliance as delta V by delta P. Okay. This is showing the normal curve of delta V by delta P, and this is the patient's curve. Okay. What do you think has happened to the compliance? The compliance has increased or compliance has decreased in this patient of the curve to the patient's curve?
Decreased.
decrease.
The compliance has decreased. Very good. Okay, so how do you know that the compliance has decreased? You look at the pressure change. Okay, so for this patient, let's say we are changing this much of pressure. Okay, this is the change in pressure. In this much change in pressure, the curve 2 is only changing in volume. Only this much change in volume is happening, whereas in curve 1, okay, if you change the pressure here to here, okay, this is the change in volume which is happening. Okay, so you compare this change in volume versus this change in volume. So if you, with a little pressure, if you have very large change in volume, that means the compliance is very high. So the patient 2 is having less compliance. So will it be obstructive lung disease or restrictive lung disease?
Restrictive.
Very good. So this is restrictive lung disease. Okay, very good. This is restrictive lung disease, and probably this could be fibrosis or all those restrictive lung disease. What if I say the patient is having like this? The graph is like this. What do you think the compliance is now? If this is curve 3,
It's increased.
compliance is increased. An example of increased compliance is
Obstructive lung disease.
Emphysema.
obstructive lung disease, like for example emphysema. Extremely good. Okay, so this patient is having, so patient 2 or the curve 2 is having less compliance. That means the example is like pulmonary fibrosis. Okay, all right, so that's your graph. Let's go to the next one. Young woman is complaining of arthralgia, and like she has various nodules on her legs. On examination, there is hepatomegaly. If you are doing biopsy of that hepatomegaly, what will you see in the liver biopsy in this patient? And this patient is having some skin lesions like this. She's having some skin nodules like this. What are these nodules called as? What are these nodules called as? Okay, young women, she's having arthralgias, she's having hepatomegaly, she's having skin nodules. On chest x-ray, she's having hilar lymphadenopathy. Laboratory is showing high ACE inhibitor. So laboratory is showing high ACE levels. Okay, first of all, what's your diagnosis?
Erythema nodosa. Sarcoidosis.
Perfect. This diagnosis is sarcoidosis. Wonderful. So diagnosis is sarcoidosis. This nodules are erythema nodosum. That's also perfect. In the serum, we see high levels of ACE in patients of sarcoidosis. Sarcoidosis is common in women's, especially black population of women's. Now they are asking that this patient is also having hepatomegaly. If you take a biopsy from the liver, what kind of pattern will you see? What will you see in liver biopsy in patients of sarcoidosis? That's what they are asking.
Non-caseating granulomas.
Very good. That's non-caseating granuloma. Remember, like they can take biopsy from n number of locations. Okay, because sarcoidosis is a systemic disease. You can get granulomas everywhere in your body. If they ask like, okay, you do the biopsy from the uvea, but you never do, your answer will be still non-caseating granuloma. Okay, so if they take biopsy from anywhere, it's just non-caseating granulomas everywhere. Okay, so the liver biopsy will show the same thing. That's non-caseating granuloma because that's a systemic disease. So you see scattered granuloma everywhere. So this is erythema nodosum, and these patients might also have hypercalcemia. Okay, so that's your sarcoidosis. Next question. Elderly man is coming to you with complaints of progressive dyspnea, non-productive cough, okay, and fatigue. On examination, there is decreased breath sounds and percussive dullness at the base of the right lung. CT shows right-sided pleural effusion and diffuse nodular thickening of the pleura. Okay, so this is your CT scan. CT scan is showing right-sided pleural effusion as well as nodular thickening of the pleura. Pleura is getting thickened. You do the thoracocentesis, you aspirate the pleural fluid, you see bloody fluid. Okay, the thoracocentesis is showing bloody fluid. Pleural biopsy is showing proliferation of epithelioid type of cells that are joined by desmosomes, contains abundant tonofilaments. They are studded with long microvilli. This is a giveaway. What's your diagnosis?
Mesothelioma.
Very good, Yashasvi. Excellent. This is mesothelioma. Okay, this is mesothelioma. Excellent. What exposure do you think the patient might have?
Asbestos.
Asbestos.
Asbestosis. Okay, if I ask you what's the most common kind of cancer you can get because of asbestos exposure, your answer is
Mesothelioma.
no.
No, bronchiocarcinoma, bronchogenic carcinoma.
Bronchogenic carcinoma. Okay, bronchogenic carcinoma is the most common cancer you get from the mesothelioma. If they ask about which of the following is the more specific kind of cancer, then your answer is mesothelioma. Is it okay?
Yes.
Perfect. All right, so this is again mesothelioma. Okay, what kind of immunohistochemical stains you can get? Immunohistochemistry would be positive for
Cytokeratin.
cytokeratin positive. Okay, this is showing cytokeratin positive. This can be also one positive for one special stain, that is calretinin. Okay,
Calretinin.
perfect. So this is mesothelioma. What other bodies you see here? What other bodies
Some
you
more
can see?
bodies.
Very good. So these are cuboidal cells with abundant tonofilaments. We see microvilli, and the patient will have exposure of asbestos. Okay, as exposure of asbestos, which lobe of the lung will be involved?
Upper lobe.
Asbestosis
Lower
is
lobe.
lower lobe of the lung. Very good. Okay, so it's lower. So yes, um, it's like asbestos is work. People work with the roofs. Okay, and that's why we have lower lobe involvement. Upper lobes are involved in coal workers disease, silicosis, and berylliosis. Those conditions have upper lobe involvement, but asbestosis is the special one which has lower lobe involvement. Perfect. That's all about asbestosis. Excellent, excellent. Okay. Elderly man after motor vehicle accident had spleen laceration. He underwent emergency laparotomy. During surgery, he dies despite of aggressive resuscitation efforts. Autopsy showing thickening inside the chest walls. Lung examination shows fibrosis of the lower lobes. Pathological examination of these fibrotic areas reveals what findings? First of all, tell me if you see some of the thickening inside the chest wall, he's having fibrosis of the lower lobes, he's elderly man. What are you thinking about?
Interstitial lung disease.
Interstitial lung disease. This is a type of definitely interstitial lung disease. If I just give you an example, okay, that would be just giveaway. Okay, what are this thickening inside the chest walls? Thickening inside the chest walls and lower lobe fibrosis. Karan is saying ARDS. This is not ARDS. ARDS will not show some thickening of the chest wall. It will be just diffuse white out. Okay, all the alveoli will be filled off the fluid. This is not ARDS. He died of hemorrhagic shock. He didn't die of ARDS. Probably he could be like one of the factors, but this is not ARDS. Okay, what are you thinking, guys? Okay, what if I say this is an occupational lung disease? Where do you see thickening inside the chest walls, and where do you see fibrosis of the lower lobes? These are two important things.
Asbestosis.
Very good. This is asbestosis, okay? Because this thickening inside the chest walls are called as pleural plaques and fibrosis of the lower lobes, okay? That's what we said, okay? Asbestos involves the lower lobe and your fibrosis, and this thickening of the chest walls are nothing but the pleural plaques, okay? If you take a biopsy of this like lower lobe involved segments, what do you see? What kind of bodies do you see in asbestosis? Which are
Heterogeneous.
ferruginous bodies. Very good. Ferruginous bodies which are actually made up of like surrounded by what element? These bodies are surrounded by what metal? It's iron. Okay, so ferruginous bodies are nothing but like bodies which are surrounded by iron, which can be stained with the Prussian blue stain. Okay, so these are ferruginous body. Perfect. So this is asbestosis. If you take a biopsy, you find ferruginous body. These are also called as dumbbell-shaped bodies. Okay. Perfect. So if they ask about what occupation can lead to this, of course, you know that this is asbestosis, but this can be insulation of the roofs, shipbuilding, and all the pipe works. Okay, pipe works. Please remember plumbers because they are very high risk of asbestosis. Okay. If the patient comes to you, like for example, elderly men, he's coming with dry cough, progressive exertional dyspnea, he was an ex-smoker. On examination, there is bilateral inspiratory crackles and there is also digital clubbing. CT is shown here. You see extensive fibrosis. Okay, how do you know this patient is having extensive fibrosis? Is because you see a lot of honeycombing right here. There is a lot of honeycombing, and because of fibrosis, you see radial traction. So you see a lot of fibrosis, and they are asking, okay, I'm just saying, okay, this patient is having a lot of fibrosis, and you have to tell me what happens in fibrosis to type 1 pneumocytes, type 2 pneumocytes, basement membrane, and fibroblast. Okay, let's start with the type 1 pneumocytes. Okay, tell me in fibrosis what happens to the type 1 pneumocytes. They'll be more functional or they'll be damaged?
Damaged.
Damage.
Damaged. Very good. So if I ask you about the numbers, they'll be increased or decreased?
Decrease.
Decrease.
Very good. So type 1 pneumocytes, they are damaged in fibrosis, so they'll be decreased. Okay. Which out of the following, type 1 or type 2 pneumocyte, is called as a stem cell of the lung? Type 1 or type 2? Type 2 pneumocytes are the stem cells. Very good. So they'll be increased in number if there is some damage, or they'll be decreased in numbers?
It's increase.
Increase.
Okay, perfect. So stem cells will be increased in numbers. Okay. Now the problem here is the catch. Okay, if no doubt the type 2 pneumocytes will be increased in number, type 2 pneumocytes will try to form further more type 2 pneumocytes, and also they'll try to form further more type 1 pneumocytes. Okay, but the problem with interstitial lung disease and fibrosis is there is no doubt type 2 pneumocyte hyperplasia, but those hyperplasia will not be able to convert or differentiate type 2 pneumocyte into type 1 pneumocyte. Okay, so there is failure of differentiation from type 2 to type 1 pneumocytes. Okay, so no doubt the type 2 pneumocyte numbers will be high, but there will be failure to differentiation from type 2 to type 1. And because of lot of damage, what will be the basement membrane? Will it be dysfunctional or functional?
Dysfunctional.
It will be dysfunctional as well. Okay, because there is a lot of fibrosis happening, what will happen to the numbers of fibroblast?
Increase.
Increase. Perfect. So this is what happens in lung fibrosis. Okay, so type 1 pneumocyte less because of injury, type 2 pneumocyte upregulated because that's the body's response, because they are stem cells. Basement membrane will be dysfunctional and fibroblast will be increased. Okay, this is fibrosis, and if it's rapidly progressing, we call it this as idiopathic pulmonary fibrosis. Okay, let's go to the next question. A young woman is complaining of fatigue, exertional dyspnea, and cough. Pulmonary examination is normal. There is non-tender cervical lymphadenopathy. If I say the patient is having lot of lymph nodes, if I say there are like multiple lymph nodes which are sub-centimeter in measurement, sub-centimeter, that means they are like less than 1 centimeter, a lot of lymph nodes in the neck. Okay, if a patient is coming to you, if I on palpation I see a lot of sub-centimeter lymph nodes in the neck, what will you diagnose? What's your diagnosis?
Sarcoidosis.
What?
Sarcoidosis.
Sarcoidosis.
Okay. So if you see a patient, okay, a patient is coming to you and you examine a lot of just like lymph nodes, sub-centimeter lymph nodes, and you say the patient, oh my God, you just diagnosed sarcoidosis of that patient without even biopsy?
No, it might be a cancer.
Okay.
Without
So,
biopsy, we cannot say cancer. If we cannot say sarcoidosis, then
okay, so your second answer was cancer. Okay, just like a lot of sub-centimeter lymph nodes and you diagnose the patient with cancer? No. Third option. What do you say?
infection.
Infection. That's one possibility. But on palpation, there is no tenderness, and patient is not having fever, chills, WBC counts are normal. So is it infection? Okay, what kind of infection do you think? Is it bacterial or viral? Okay, one of the answer from the YouTube is infectious mononucleosis. In infectious mononucleosis, you might have like enlarged tonsils, you may have white exudate, you have enlarged lymph nodes, but they'll be more than a centimeter. And that's usually post-occipital, but you may also see anterior lymphadenopathy. This can be infectious mononucleosis, but this patient is not having infectious mononucleosis. Okay, can this be normal? Sub-centimeter lymph
Yes.
nodes? Yes,
Yes.
it is normal. It is normal. If a patient comes to you and on examination you see, you palpate your own lymph nodes, you'll be able to palpate submental, submandibular. Okay, you'll be able to palpate some of the anterior cervicals, and if somebody has some of acnes, you'll definitely be able to palpate submental and submandibular lymph nodes. Okay, and anterior cervical. And if you have acne in the scalps, you may also have like some of the posterior occipital lymph node. This is completely normal. You may have because a lot of like enlarged lymph nodes because of inflammation, infection, but if you sub centimeter, less than 1 centimeter lymph nodes, they are normal. Okay, so do not like overdiagnose anybody with sarcoidosis or cancer or infection if you palpate some of the lymph nodes. This is very, very normal. Okay, if I say the patient has enlarged lymph nodes, that is tender, that's when I start thinking about infection. If I say that and there is enlarged lymph node, it is tender and it is mobile, do you think that can be cancer? And like enlarged lymph node that is mobile, that is tender, do you think that can be cancer? In cancer,
No.
we might not expect tender lymph nodes. So this is probably some lymphadenitis because of infection. If I say the patient is having painless lymphadenopathy, which is large and that is mobile, that can be cancer, that cannot be cancer. We need biopsy to like further diagnose. And if I say there is enlarged lymph nodes, enlarged lymph node that is fixed, that is not moving, what do you think? Is it cancer? Enlarged lymph node which is fixed, which is not moving, is it cancer? The answer is yes. Possibly cancer. Okay, if it is fixed, we are thinking about cancer. Okay, so if they mention about non-tender cervical lymphadenopathy which is sub centimeter, do not like do over diagnosis. This can be a normal finding as well. But this patient is having hypercalcemia because serum calcium level is 12. Chest x-ray is showing scattered nodules. Okay, lymph node biopsy is showing non-caseating granuloma. So you make obviously a diagnosis of sarcoidosis. They are asking why the calcium levels are elevated in the patients of sarcoidosis. Your answer is? Answer why the calcium levels are elevated in the patients of sarcoidosis. Your answer is? Vitamin D what?
Hyperactivity of alpha 1 alpha hydroxylase.
Okay, hyperactivity of 1 alpha hydroxylase in the PCT. 1 alpha hydroxylase is normally located in the PCT. Is there hyperactivity of 1 alpha hydroxylase in the PCT in the patients of sarcoidosis? In the macrophages. Okay. Is it okay, Meet?
Yes.
It's not in the PCT, it's in the macrophages. Okay, so there is 1 alpha hydroxylase activity of the macrophage that's upregulated. That's why you convert 25 hydroxy vitamin D to 125 hydroxy vitamin D. When you have a lot of 125 hydroxy vitamin D, you absorb calcium from the kidneys, your GI tract, you're everywhere. Okay, that's why you have hypercalcemia. Perfect. So that's hypercalcemia of sarcoidosis because of activated macrophages. What do you think in this patient will be the level of PTH? This patient, same patient, levels of PTH?
Decreased.
Low.
Decreased. Very good. Because the calcium levels are high, your PTH will be low. And if your PTH is low, what will be the levels of phosphate in this patient?
Decreased.
Increase.
Okay, increased. What? Increased or increased?
Increase or
I say
normal?
decrease.
Phosphate, see, parathyroid hormone is phosphate trashing hormone. So if there is no phosphate trashing hormone, it will be built up in your serum. Okay, so phosphate will be increased in serum if your phosphate trashing hormone is low. Okay, so this is serum phosphate level. Serum phosphate levels will be definitely high or normal in patients of sarcoidosis because PTH is low. All right. Okay, so let's come to the next one. 50-year-old man is coming with 8 months history of progressive shortness of breath while exertion. His co-workers have experienced the similar symptoms. On examination, there are diffused fine crackles, chest x-ray showing nodular densities in both lungs, most prominent in the apical region. Calcification of hilar lymph node is also seen. Okay, there is calcification of the hilar lymph node. When you do the transbronchial biopsy and you expose that material to the polarized microscopy, there is birefringent positive particles are seen. Okay, and you see a lot of collagen fibers as well. What's your diagnosis? This is also one of, I would say, giveaway which we talked in our classes. Silicosis, excellent, Yashasvi. This is silicosis. Okay, so there were many hints which were pointing out towards silicosis. This man was already having progressive shortness of breath, but his co-workers were also experiencing. Okay, so that's one of the occupational related hazards. There is diffuse fine crackles because of silicosis induced fibrosis. And what is this called as? Calcification of hilar lymph nodes in silicosis. There's one word.
Eggshell calcification.
Excellent. This is eggshell calcification. This is very important. Okay, egg cell calcification with birefringent particles. Okay, because silica is birefringent. Okay, who engulfs the silica particles and they become birefringent? Of course.
Mine workers.
Huh?
Mine workers. Or
No.
No.
Like mine workers get
Yeah.
this. Like which macrophages engulf the silica particles, right?
oh yes, macrophages.
Macrophages will engulf the silica particles and they go mad and like they lay down, they call fibroblast and they lay down a lot of collagen. So this is silicosis. Okay, if I say the same patient, okay, after 1 year he has developed apical lung cavity, now has night sweats, weight loss, and he's having like mild fever with chills with apical lung cavity. What do you think?
Bronchogenic carcinoma.
No. Silicosis just after a year, I'm saying. Just after a year. If I say the patient has developed tuberculosis, very good. Because silica increases the risk of tuberculosis. Why? I just explains because of the macrophage dysfunction. Type 4 hypersensitivity is like macrophage are the one which can form granuloma around the tuberculous bacteria, and macrophage, if they are gone because silica is damaging your macrophage, you have increased risk of tuberculosis. Okay, so excellent. TB can be seen if the patient has silicosis. Okay, so this is no doubt silicosis, and you might see egg shell calcification in silicosis. Next question. A young man is complaining of exertional dyspnea and dry cough for the 7 months. His saturation while lying down is 96 and drops to 88% after 6 minutes of walking. Whenever you see 6 minutes of walking, actually 6 minutes of walking is advised to any patient who has, maybe some cardiac or pulmonary related shortness of breath. Okay, that's how you test and you track the
In
patient.
COVID also.
Yes.
Yes.
This is how you track the patient. Okay, let's say I'm starting 6 minutes of walking today. I want to know what has happened after a month. You can know by chart measurement of 6 minutes of walking. That's a standard test if you have any cardiac or pulmonary related shortness of breath. Okay, so but anyways, this patient is having crackles on the both lower lobes of the lung. Chest x-ray is showing reticular densities in both lung fields. Lung biopsy is showing infiltration of inflammatory cells, predominantly lymphocytes, and poorly formed non-caseating granuloma and moderate alveolar septal fibrosis. This is a non-specific question, but I would be really impressed if somebody can give me the diagnosis. I'll also share some hints here. Let's say this is a young patient. and he's having some hypoxia with walking. Chest X-ray is showing reticular densities. Lung biopsy is showing lot of inflammatory cell, predominantly lymphocytes. And there's one thing I would say, okay, let's say lymphocytes are more than 30%. And this patient,
Hypersensitivity pneumonitis.
very good, Yashasvi. Excellent. This is hypersensitivity. You know, this is really a tough question. Hypersensitivity pneumonitis, when you see lymphocytes more than 30%, and this is, see, hypersensitivity pneumonitis is what kind of hypersensitivity? Type 1, 2, 3, 4.
Type 3.
It is type 3 and type 4 mixed. That's why they have written this. This is showing poorly formed non-caseating granuloma. Okay. And because of that, you might also see alveolar septal fibrosis. Now, this, see, hypersensitivity pneumonitis can be acute or chronic. Okay. This patient probably had chronic hypersensitivity pneumonitis that has progressed to fibrosis as well. Okay. So, whenever you see this kind of scenario where you see predominant lymphocytes, okay, with poorly formed non-caseating granuloma with a lot of fibrosis, it's hypersensitivity pneumonitis and it's young man. The reason why I would not choose sarcoidosis here is, see, this is how you see, you do not have to assume in the questions. Okay, this is how you approach the question. If I would choose sarcoidosis, first of all, I would expect a woman, as at least in the USMLE, okay? I would expect a woman to be in the question. No doubt it will be a young woman. They would have written either she is African American or no. They would have written some kind of electrolyte abnormalities. Like, for example, we would expect hypercalcemia, we would expect polyuria, abdominal pain, psychiatric manifestations, and there'll be perfectly formed non-caseating granuloma in sarcoidosis. Do not assume the things in questions. Okay, so this is hypersensitivity pneumonitis and this is type 3 and 4 mixed. Okay, excellent. Okay, if I say the patient is having some exposure, okay, now this hypersensitivity pneumonitis because of exposure to anything, like for example, it can be exposure to animal proteins and like molds, or like I have seen patient who had hypersensitivity pneumonitis because of like birds excreta, okay, the pigeon droppings. You can still have hypersensitivity pneumonitis because of that. Now, very important, when you are sitting in your outpatient department and you want to diagnose hypersensitivity pneumonitis, do not say, okay, just you are living near the birds, you have hypersensitivity pneumonitis. If you remove the patient from that exposure, their symptoms should go away. Okay, then and only then you can make a diagnosis of hypersensitivity pneumonitis. And you send the patient to diagnose, and you send the patient for ANA. Do you think the ANA will be positive in hypersensitivity pneumonitis? No, we don't expect ANA positive. If the ANA becomes positive, that means we are going towards other side, other type of autoimmune diagnosis. Okay, hypersensitivity pneumonitis. Okay, like if you just go to some of the pulmonologists, this is their, I would say, escape diagnosis. If you don't find anything, you just diagnose hypersensitivity pneumonitis. But in reality, their symptoms should go away when you, like, at least after 6 weeks when you're removed from the exposure, at least in the acute settings. But if symptoms does not improve, that means it is something else. Okay, very important. All right, next question. Man is complaining of malaise, night sweats and cough for the past several weeks. He lost 4 kgs. He is working as a respiratory therapist at Urban Hospital. Chest X-ray shown below. This is their chest X-ray. A palpable lymph node in the supraclavicular bed is biopsied. Pathology reveals well-formed non-caseating granuloma. What is your diagnosis? Now, this is like entirely opposite thing which I explained from the last question.
Sarcoidosis.
Excellent, Yashasvi. Why?
First of all, non-caseating granuloma.
This is not. You are sarcoidosis expert, Yashasvi.
Yes.
This is this is non-caseating granuloma. Okay, first of all, what's your impression if I say men, weight loss, lymph node at the supraclavicular area, and he's working at as a respiratory therapist. Like, my first impression is some infection. What kind of infection do you expect here? What?
Tuberculosis.
TB, excellent. Okay, because you expect supraclavicular lymphadenopathy. He's working as a respiratory therapist, and you get like all night sweats and weight loss and all those things. But here the catch is just one word: non-caseating granuloma. In TB, we would expect caseating granuloma, and that will be acid fast positive. So here is like see, I told, like, okay, whenever you are like thinking about sarcoidosis, I would expect females, but this is how the things may go to the other side. Okay, they asked about men's, and that too non-caseating granuloma. So we do see sarcoidosis in men's as well. Okay, excellent. So this is sarcoidosis. Of course, in the chest X-ray, it's showing the same thing. You see hilar lymphadenopathy. Okay, and if you take a biopsy of this is non-caseating granuloma. Okay, perfect. So this is again sarcoidosis. Very good. Elderly man is complaining of cough with occasional hemoptysis. He's having night sweats, unintentional weight loss. He worked in the gold mines. He's having history of silicosis. On examination, there is diffuse fine crackles with the right upper lobe of the lung. Chest X-ray showing diffuse small nodules, hilar lymphadenopathy with predominant calcification, and cavitary lesion in the right upper lobe of the lung. Sputum sample is sent for the appropriate staining and culture. The patient is okay. First of all, tell me, what's your diagnosis?
Tuberculosis.
TB. Excellent. Why do you think? Because he has history of
Silicosis.
silicosis. Okay, and silicosis, when the patient inhales silica will be engulfed by the macrophage, and there'll be macrophage dysfunction, and because of macrophage dysfunction, this patient has increased risk of tuberculosis. Okay, and that's what your answer is. Because of macrophage dysfunction, you get tuberculosis. Okay, because of impaired macrophage dysfunction, you see cavitary lesion, especially in the upper lobe. That's predominantly a Mycobacterium TB infection. Okay, and if you want to diagnose, you have to send the sputum sample for AFB staining. Okay, and now these days we also see quantiferon gold. Okay, so you can also send the sample for the quantiferon gold test. Okay, so this is TB. Excellent. Like which you get in the silica. Okay, this is an important question as well, but we already discussed this in our classes. Okay, middle-aged man is coming to you with dyspnea. The graph on the right side is showing patient's work of breathing. On the graph on the left side is showing normal work of breathing. Keeping the minute volume same, why this patient is having the graph which is shown on the right side here. Okay, if I say this is the normal work of breathing, this is the patient's work of breathing, what kind of lung disease do you expect in this patient?
Obstructive.
Okay. All right.
Oh no,
So,
it's restrictive lung disease.
okay. How did you come to the conclusion?
But the work of breathing is increasing both, right? Obstructive and restrictive.
Work of breathing is increased in both in obstructive and lung disease. The patient does something so that they can, keep the work of breathing minimal.
But airflow is normal here. I mean,
okay. So they have not shown any elasticity graph. They have not shown any airflow graph. They have shown average of both airflow and elasticity, and that's how you come to the graph. Okay, first of all, tell me, if this is your respiratory rate on the x-axis, this is the work of breathing. I'm saying the work of normally I can keep my work of breathing when I breathe this many times per minute, let's say 12 times per minute. If I breathe 12 times a minute, my work of breathing will be minimal. In this patient, how many times he has to breathe per minute in order to keep his work of breathing minimal? Somewhere at a higher respiratory rate, right? At around, let's say, 20 times per minute. So this patient has to keep his respiratory rate higher in order to keep the work of breathing minimal. So Actually, I have to explain all like both graphs of obstructive and restrictive in order to make you understand. But since we have already discussed this, now you guys will tell me what is this, obstructive or restrictive?
Restrictive.
This is restrictive. Very good. In restrictive lung disease, the patient, if they breathe deeply because of like lot of expansion of the lung volume, the recall will be very fast because they have a lot of elastic tissue. When they breathe so much, there'll be a lot of recoil, so there'll be a lot of resistance if they breathe deeply. So they'll breathe slowly, their tidal volume will decrease. Okay, and when the tidal volume is decreased, if you want to keep the minute volume constant, this is what the question said, right? Minute volume is constant. So if you want to keep the minute volume constant, you know that you want to breathe shallow in restrictive lung disease, because if you breathe deep, there'll be a lot of recoil of the lung. So you need to keep the tidal volume less in restrictive lung disease. And if you want to keep the tidal volume less, what you should do to the respiratory rate if you want to keep the minute volume constant? Increase. Okay, so this is how restrictive lung disease patient keep their work of breathing minimal. This is an extremely important concept. Okay, so this is, I think, what you were saying, Yashasvi. This is elastic and this is airflow resistance. Okay, if you look in the restrictive lung disease, the elastic tissue is so high that if you keep your respiratory rate very low, like let's say only 5 times, if I say the restrictive lung disease patient, okay guys, like you have to breathe only 5 times a minute, lot of elastic force. Okay, lot of elastic force because of lot of elastic tissue. Okay, so if they breathe very less per minute, their work of breathing will be very high. They'll spend lot of energy in order to overcome that elasticity. In contrast to obstructive lung disease, because there is obstruction, if they breathe, their airflow resistance will be high because of constriction, because of the airflow constriction. If they breathe heavily, their airflow resistance will be high. So they try to breathe nice and slowly, the obstructive lung disease, because their elastic tissue is already digested. In emphysema, your elastic tissue is already digested. In chronic bronchitis, there's nothing happening to your elastic tissue. That's why the graph is like little near to the normal in like obstructive lung disease patients. Okay, so there's problem if you just compare these two graphs. The problem is of elastic tissue in restrictive lung disease, and problem is with the airflow resistance in obstructive lung disease. So in summary, if I just show you 2 patients, okay, and if I just compare the rates of breathing, if I say this is a patient, okay, and you have to identify what kind of lung disease they have. If I say the patient is breathing like this, what is your diagnosis? Restrictive or obstructive lung disease?
Restrictive.
It is restrictive. They are breathing small tidal volume and rapidly. Okay, if you have a patient who is sleeping by you and they have restrictive lung disease, you can hear their breathing pattern. If I say the patient is breathing like this, what's your diagnosis?
Obstructive.
That's obstructive lung disease. Okay, especially pursed lip breathing in obstructive lung disease patient. Okay, excellent. Okay, that's your work of breathing. Let's go to the next question. Elderly man is coming to you after motor vehicle accident. He was hospitalized, and as a part of diagnostic workup, you do a CT scan, and your CT scan is showing pleural thickening like this. What occupational history do you expect here?
Asbestosis.
Asbestosis.
Very good. What are these? What are these pleural thickenings? Okay, these are the these are the pleural plaques. Perfect. This is mesothelioma. See, pleural thickening does not mean mesothelioma. You can see pleural plaques in even asbestos exposure. Okay, so just asbestos exposure can give you pleural plaques, and then later on these patients can develop mesothelioma. Just pleural plaques does not mean mesothelioma. Okay, so these are pleural plaques. You can see the pleural plaques in the chest x-rays as well. Okay, so you see a lot of calcifications here. All right, let's go to the next question. Okay, if they ask about occupation, insulation, okay, because that's what asbestos or plumbers. All right. This is another intelligent question. Elderly man is coming with shortness of breath. During pulmonary function test, the patient performs FVC, forced vital capacity. You ask the patient to breathe maximally, expire maximally in rapid time. That's forced vital capacity, okay? You know, your pulmonary function test therapist should be so much motivating. Otherwise, you won't get PFT finding accurate. You have to like motivate the patient. Okay, exhale. If you see like, you know, nurses or some of the respiratory therapists doing PFT, you will see, wow, you'll feel like, oh my, let me just expire. You have
They
to
have the
encourage the
different level of
patient.
energy.
What?
They have the different level of energies.
Absolutely, yeah.
Like
They
they are shouting.
expire. Yeah, then the patient will expire rapidly. Okay. This is what the graph is shown. This is the normal PFT, the black one, and they are asking what happened to the blue patient. What's your diagnosis?
Restrictive lung disease.
Restrictive lung disease.
Wow. How did you guys know?
The capacity decreases.
Okay, which capacity? Forced vital capacity?
Yes.
Forced vital capacity has decreased. Okay, I'm just drawing some of the lines here. You have to tell me what is FVC. This is A, graph A. This is graph B. Which is FVC in blue patient?
A.
What is FVC in the blue patient?
A.
Okay,
A
I
is
know
a
what.
FEV1.
Huh?
A is a FEV1, right? And B is
Yeah.
FVC.
Yes, actually, I know you got confused with this point, but this is what the patient what like exhaled or like to the whole, right? So, whatever you this was the maximal inspiratory capacity, okay, and you expired all the way up to down. This is FVC, and if I just say, okay, from here to here, okay, this much is FEV1. Okay, because this is happening in 1 second. From here to here is FEV1, from here to here is FVC, forced vital capacity. So both FEV1 and FVC are decreased in this patient. That's why we came to the diagnosis, okay, this is restrictive lung disease. Okay, if I draw the graph like this, okay, this patient is having, this is let's say red patient. This patient is having graph like this. What's your diagnosis? This is hypothetical graph, but still, what's your diagnosis? In this red patient,
Obstructive.
this is obstructive lung disease. Okay, in obstructive lung disease, you are like anyway able to reach FVC, but your FEV1 is so less. Okay, in 1 second, because of obstruction, if FEV1 is forced vital capacity, forced expiration in 1 second. Okay, FEV1 forced expiratory volume in 1 second. FEV1 is like how much you can exhale in 1 second. In 1 second you can exhale very less in obstructive lung disease patient. Okay, so if I say the red graph, it is obstructive lung disease. If I say the blue graph, it is restrictive lung disease. Okay, the reason why this red graph is obstructive lung disease, what happens to the FEV1 by FVC ratio in obstructive lung disease patient?
Decrease.
FEV1 by FVC ratio is very less because your FVC is too much less. Okay, because of obstruction you won't be able to expire a lot in 1 second. In restrictive lung disease, your FEV1 by FVC ratio is
High.
either normal or high. Okay, now you look, this patient had capacity of only this much, but according to his capacity, he exhaled most of his air in 1 second. In restrictive lung disease, you are able to exhale most of the air in 1 second, but of course it is less than the normal. So in obstructive lung disease, you see how much they could exhale in 1 second, only this much. Rather, they had like lot of capacity, and in fact in obstructive lung disease your total lung capacity increases, okay, and your total lung capacity decreases in restrictive lung disease. All right, I hope this is clear for everyone. Is it okay for everyone?
Yes.
Yes, sir.
Yes.
Okay, perfect. All right, so this is actually restrictive lung disease, and you have to choose any of the restrictive lung disease if it's in the option. Okay, so in this case it was fibrosis, so you can choose fibrosis. Okay, what's the golden number if I say FEV1 by FVC is 88%? Is it normal?
No. 80%
Yes.
is no
Yes.
normal.
88% is normal. Okay, you have to like look at the ratio. If anything is more than 70% in any ratios of your PFT, that is normal. Okay, FEV1 by FVC, any ratios, okay, any capacities, any volumes, if they are more than 70% or 80%, it's normal. Okay, if I say
It's
it's less
normal.
than
Why it's normal? 88% is increased, right?
no, like 88% is increased, meaning, so how much
Like
do you think
meaning
should be
of
the normal?
80%. Below 80%, like is 70% is obstructive, and above 80% is restrictive lung disease.
Oh, see, this can be normal or restrictive lung disease. This can be normal patient, right? What if he is athlete? His FEV1 will be high. Okay, so
Okay.
you can so this can be normal or high. I'm saying if it is anything above 70% is like you consider that as normal. Okay, it can be athletes as well, but then you have to check the FVC. If the FVC is like also low and if even is also low, then you can go to the restrictive lung disease diagnosis. Is it okay, Meet?
Okay. Yeah.
So any ratios you have to think as abnormal if your cutoff breach is 0.7 or 70%. Okay, if it's less than that, or if even is less than 0.8 or 0.7, then it's considered as abnormal. All right, that's the number you might want to keep in your mind. All right, let's say we have a construction worker. He had significant exposure to asbestos during the building project 25 years ago. His chest imaging now is normal. He is concerned about the risk of developing cancer in future. Due to his occupational exposure of asbestos, this patient is at greatest risk of developing which malignancy? Your answer is?
Bronchogenic.
Bronchogenic carcinoma.
Very good. Bronchogenic carcinoma. Okay, if you have a history of asbestosis, your development of bronchogenic carcinoma is high. Do not choose mesothelioma here. Okay, and if they ask about this arises from what, then your answer is bronchial epithelium. Okay, mesothelioma is specific for asbestosis, but bronchogenic carcinoma is most commonly seen with asbestosis. Okay, this is very, very important. All right, overall, if I say just play odds, this patient is having lung cancer. Overall, what is most common? This patient is having some malignancy of the lung. You don't know like what kind of malignancy. Just play odds. What kind of cancer this can be?
Squamous
Primary.
cell.
Adeno.
Adeno.
If I ask about primary lung cancer, okay, like the cancer is aroused from the lung itself, then your answer is adenocarcinoma.
Okay.
Adenocarcinoma of the
Metastasis
lung.
is more.
Yes, Mets are most common because lungs are the favorite site of all the cancers to drop in. If I just play odds, metastasis of the lung is most common, followed by adenocarcinoma of the lung. Okay, and adenocarcinoma of the lung are common in which gender?
Females.
Females more. Do they need history of smoking?
No.
No.
No smoking. Okay, so adenocarcinoma is the most common primary cancer of the lung. Okay, followed by like squamous cell carcinoma, and then you have all those like small cell and large cell and like carcinoid. So most common primary lung tumor is adenocarcinoma of the lung, of course, followed by metastasis. Okay, so that's the odds. Okay, elderly man is coming to you with exertional dyspnea. He's having non-productive cough. Okay, exertional dyspnea, non-productive cough. There is late inspiratory crackles in both of the lung bases. There is mild digital clubbing. Histology shows areas of dense collagen fibers and foci of proliferating fibroblast, mild interstitial inflammation, and honeycomb changes. Okay, by now you already have some diagnosis in your mind. Pharmacotherapy is aimed at which of the following that can help this patient in preventing the said pathology? What do you think the patient is having as a diagnosis?
Pulmonary fibrosis.
Perfect. This patient is having pulmonary fibrosis. Okay, now what pharmacotherapy do you know which can be used in pulmonary fibrosis?
Pirfenidone.
What?
The question.
Like pirfenidone. The drug
Perfenidone. That's perfect. Perfenidone that targets what? Perfenidone targets what? It inhibits what?
fibroblast
Starting from T,
proliferation.
transforming growth factor beta. So
Beta.
perfenidone inhibits transforming growth factor beta, so you prevent collagen lay down. And we also have like nintedanib. Okay, nintedanib targets what?
Any FGF?
Perfect. It can target FGF, it can target VEGF, okay, and it can target platelet derived growth factor. So you can inhibit all those factors, so you prevent laying down of collagen. So you can give perfenidone or nintedanib. Will they cure pulmonary fibrosis?
No,
No.
they just preventing.
Perfect.
For
They'll
more
just
fibrosis.
prevent the progression. Okay, perfect. So you can target TGF beta or FGF or VEGF or PDGF. So based on that, you can give some pharmacotherapy, nintedanib and perfenidone. Perfenidone is really expensive drug. Okay, nintedanib is easier to afford, at least here in India. So I've seen patient, they are on nintedanib, so you can give them to halt the progression to pulmonary fibrosis. Okay. All right, let's move to this. A 50-year-old male patient is coming to you with 2 episodes of low volume hemoptysis. He has chronic cough for the several years, predominantly in the morning, several recent respiratory infections. He has a history of smoking. His chest x-ray showing hyperinflated lungs, but no infiltration or masses. Okay, bronchoscopy is performed. He and biopsy of several suspicious foci of bronchial mucosa is biopsied. The microscope is showing patches of stratified squamous epithelium. Okay, this patient is having hemoptysis, hyperinflated lung. He was smoker. That means he had COPD already, and now this patient is having hemoptysis. That means you planned a biopsy and you see a lot of stratified squamous epithelium everywhere. What's happening? I know this is weird, but what kind of cancer this patient can develop in future?
Squamous cell carcinoma.
Cell.
Squamous cell carcinoma. Okay, is it like initially what epithelium was present before that changed to what epithelium, and because of that what dysplasia continued?
Pulmonary epithelium to squamous epithelium.
Okay, what is exactly the exact epithelium of the lung, of the bronchial mucosa?
Pseudo-stratified ciliated
Pseudo-stratified ciliated columnar epithelium. Okay, perfect. That also has goblet cells in it. Okay, now that epithelium, when you smoke, is transformed into which epithelium?
Stratified squamous.
Stratified
Stratified
squamous
squamous
epithelium.
epithelium. Perfect. So initially we had pseudo-stratified columnar epithelium, which was having goblet cells. We wanted, okay, there is like a lot of mucus secretion, but when you smoke, when you bless your respiratory epithelium with the smoke, your respiratory epithelium will think, okay, now is the time to transform. So they transform the initial pseudo-stratified epithelium into stratified squamous epithelium. Okay, and if you continue doing that, that will undergo dysplasia. Okay, of course, this, what is this process called as? Pseudo-stratified epithelium is transformed into stratified squamous epithelium. What is this process called as, starting from M?
Metaplasia.
Ablation.
Metaplasia.
Metaplasia. If you ask the patient to stop smoking, will this
Sir,
metaplasia go?
Reverses.
Yes.
No, not reversible.
It's a,
Yes, it is reversible.
yes, it's
Metaplasia is reversible. Okay, if you ask the patient to stop smoking, this metaplasia can be reversed. Even early dysplasia can be reversed. Okay, so this is one kind of metaplasia. That's like ultimately you can get squamous cell carcinoma of the lung. You also get some other kind of metaplasia elsewhere in your GI tract when your one epithelium is converted into another epithelium. What is that called as?
Barrett's esophagus.
Barrett's esophagus, where dash epithelium is converted into dash, which is the initial epithelium.
Static.
squamous epithelium.
Stratified
Columnar
squamous
epithelium.
epithelium is converted into
Cuboidal.
columnar epithelium.
Columnar.
Columnar epithelium of the intestinal type. Okay, so because see, that happens in chronic GERD. GERD is acid. Your esophagus wants, okay, I want like a lot of goblet cells and mucinous cells to secrete mucus in order to neutralize that acid. So you convert stratified squamous epithelium to columnar epithelium. Okay, so that's Barrett's esophagus. So they were actually asking this phenomena. So this metaplasia can happen in both respiratory tract because of smoking and your GI tract because of GERD. All right. So that's two kind of cancer, and of course you get squamous cell carcinoma because of metaplasia in your respiratory tract. What kind of cancer do you get in your GI tract? In Barrett's esophagus.
Adenocarcinoma.
Adenocarcinoma.
Perfect. Adenocarcinoma of the lower esophagus. Wonderful. All right. Elderly man is now coming to with progressive confusion and lethargy. He's having persistent cough, hemoptysis, history of smoking. On examination, there is wheezing in the left lung. Serum sodium is 123. If I just say close your eyes and tell me the diagnosis, what's your answer? Smoking, lethargy. Huh?
Cell carcinoma.
Which carcinoma? Squamous
Small
cell?
cell. Small cell.
Small cell carcinoma. Perfect. It is small cell carcinoma. And now the question says, okay, chest x-ray showing mass, and you do the biopsy, and they're asking, okay, biopsy confirms the aggressive lung cancer. What kind of lung cancer do you see? That's a small cell carcinoma that secretes what? As a result of that, you get serum sodium low.
ADH.
ADH, perfect, and that is called as SIADH. Perfect. So because of SIADH, you can get like hyponatremia. If I say what will be the serum osmolarity, your answer is what? High or low?
Low.
Low. Urine osmolarity?
High.
Very good. You are expert now. Perfect. So that's small cell carcinoma. If I say what immunohistochemical stain will be positive, your answer is
Chromogranin A.
chromogranin will be positive. It's a neuroendocrine tumor, so it will be also positive for NCAM. Okay, neuronal cell adhesion molecule CD56, because that's a neuroendocrine tumor. Okay, perfect. Synaptophysin will be also positive. Neurofilament will be also positive. So all the neuron specific enolase, okay, NSE, that will be also positive. So all the markers which are related to the nerves will be positive in small cell carcinoma of the lung, because it's a neuroendocrine tumor. Okay, very good. Perfect. So that's a small cell carcinoma of the lung. Which lobe of the lung is predominantly involved in small cell carcinoma of the lung? Okay, I mean, which location? Peripheral or center? Small cell carcinoma of the lung.
Central.
Central.
Center. Okay, is it associated with smoking?
Yes.
No.
Yes. Small cell carcinoma, center, smoking, SIDH. Okay, so that's a neuroendocrine tumor. Apart from that, you can also release cortisol. You can get Cushing syndrome because of that, and you can get autoantibodies against the presynaptic calcium channels, and as a result of that, you can get Lambert-Eaton syndrome as well. All right, so that's small cell carcinoma, and you can get NCAM, neuronal cell adhesion molecule, which are CD56 positive. Okay. Oops. Elderly man is coming with non-productive cough, anorexia, unintentional weight loss, lot of smoking history, enlarged right supraclavicular lymph node. Imaging reveals large mediastinal mass causing tracheal deviation. Enlarged lymph node is biopsied, and microscopy shows small ovoid cell with scant cytoplasm and high mitotic count. Immunohistochemical stain is positive for chromogranin. What's your answer? Immunohistochemistry
Small
positive for
cell carcinoma.
chromogranin.
Small
Small cell,
Cell
or
carcinoma.
this is small cell carcinoma again because it's a neuroendocrine tumor, and it will be positive for chromogranin, and there is a lot of smoking history. Do you think the small, okay, let's not go there. So that's a small cell carcinoma. Again, you see a lot of small cells, just like lymphocytes, and this is chromogranin positive. Okay, a 56-year-old woman comes with persistent cough, exertional dyspnea, and recent unintentional weight loss. She never smoked. Women never smoked, dyspnea, weight loss. Imaging shows irregular mass. You do a diagnostic thoracocentesis and you send that for cytological evaluation. If at all you find cancer, what kind of cancer do you find in this
Adeno.
woman?
Adenocarcinoma.
Very good. This is adenocarcinoma of the lung, which you find in women who have never smoked. Very good. It's adenocarcinoma of the lung. See, these are the incidents of cancer. Adenocarcinoma followed by squamous, followed by small cell, followed by large cell, followed by bronchial carcinoid. Okay. What's one of the paraneoplastic syndrome you get from adenocarcinoma of the lung?
Hypertrophic osteoarthropathy.
Very good. That's hypertrophic osteoarthropathy. Excellent. Okay. 50-year-old man, he's planning for total knee replacement. Preoperative chest x-ray demonstrates a nodule, and further imaging is showing a hematoma. If you take a biopsy of this hematoma, what will you see in that hematoma? If you take a biopsy of this hematoma, this is lung nodule, right? So what are this lung nodule composed of? If you take a biopsy of this lung nodule,
Macrophages.
What are hematomas by definition?
Bleeding knees.
What?
Sorry.
What are hematomas by?
Collection
Jumbled
of the
up,
tissue.
These are jumbled up tissues. Very good. So jumbled up tissues of that particular anatomical locations are called as hematomas. Okay, so tissues are actually from there only, but they are jumbled up. Okay, so like for example, you can see cartilage, respiratory epitheliums, and all those kind of thing in that tissue. Just a second.
Is it pulmonary emboli?
Pulmonary embolism. What?
Yeah.
I mean, where do you think, because of this round lesion, 1.5 centimeter round region, you get pulmonary embolism? I don't know, like what did you confuse with? Like a patient was planning for total knee replacement, okay? And if you get a round lesion in the periphery of the upper lobe of the lung, if it were pulmonary embolism, you might expect, okay, this patient is having dyspnea, hypoxemia, tachycardia, and all those things. This is something in the upper lobes that's like having a mass kind of lesion. Okay, so if I said hematoma are like of specific location, you see jumbled up tissues there. So you can expect some cartilage, you can expect some respiratory epithelium and all those things in this hematoma. One other differential diagnosis which I want you to tell you guys is if you have some tissues which are of normal architecture but are located somewhere else, what is that called as? Normal tissue at abnormal place. Gurpreet has said something. This is not hematoma. Normal tissue, these are jumbled up tissue which are normal at normal place only. That is called as hematoma. Like for example, if you have um, lung tissues, if that lung tissues are just abnormal and jumbled up and they are found in the lungs as well, that is called as hematoma. If I say normal tissue, normal architecture, but they are found at abnormal place, what is that called as? What is that called as? Starting from C?
Choristoma.
Cholesteatoma.
It's choristoma. And one very good example of that is
Meckel's
starting from
diverticulum.
Meckel's diverticulum. You see normal gastric mucosa at an abnormal place, which is normal architecture as well, right? So Meckel's diverticulum is an example of choristoma. Perfect, perfect, perfect. So you might see nodules of cartilaginous tissue, respiratory epithelium, adipose tissue, which are all jumbled up at a normal place. That is called as like a hematoma, and this is lung nodule. And you'll study about lot of lung nodules. I mean, a lot about lung nodules in step 2 of their workup and what you should do and all those things. But anyways, I'll tell you one first initial step. If you see lung nodules in any patient, your first step is to compare that lung nodules from your previous x-rays. If you have lung nodules now, you have to compare that lung nodules from the previous x-rays. Okay, that's very important. But if you don't have any previous x-rays and if you see lung nodules for the very first times, you have to ask the patient to undergo HRCT thorax. Okay, that's very important. All right, let's go to the next question. Elderly woman is coming with cough and scant white sputum. She lost her weight. Ex-smoker with 25 pack per year history. Diagnosed with mild COPD. Chest CT is showing mass in the right lung. Light microscopy is shown here. What's your diagnosis? What's your diagnosis? If you see this kind of thing in biopsy, is it squamous cell carcinoma? Is it adenocarcinoma? Is it small cell carcinoma? Is it carcinoid or something else?
Squamous cell carcinoma.
Why?
Because she has a history of smoking.
That's what you all wanted you to be in trap.
Adenocarcinoma.
This is adenocarcinoma. Why?
There are glands seen.
Yes, there are a lot of glands. Biopsy shows a lot of glands. Okay, despite of she's having history of smoking. Now see, adenocarcinoma can be seen if you don't have smoking history. If at all you smoke, that does not mean you don't have like chances of getting adenocarcinoma. That's after all the most common cancer. Okay, the reason why they said like this can be seen in non-smoker, it means like it does not need smoking as an inciting factor, but you still can get adenocarcinoma of the lung even if you smoke. Okay, so this is adenocarcinoma. Of course, these are glands, okay, with high NC ratios. You see a lot of dark blue cells with high NC ratios, and this is adenocarcinoma of the lung. Perfect. Okay, so this is adenocarcinoma of the lung, most common cancer. Elderly man with mild headache, lethargy, sodium levels are low. He's a smoker, and osmolarity of plasma is low. Osmolarity of the urine is high. Chest X-ray showing overinflated lung fields, and there is hilar mass. Biopsy would show what?
Small cells, I mean
Small
small
cell.
blue cells.
Small cell carcinoma.
Biopsy
Why?
shows
Okay,
SIADH.
perfect. This is SIADH. So this is small cell carcinoma of the lung. You can get SIADH because of that, and that's why this patient is having hyponatremia. And as a result of that, this patient is having lethargy and mild headache and all those things. You can also have hyponatremic seizures because of this. Okay, this is very, very important. All right, so this is small cell carcinoma of the lung. You can also get like cerebral ataxia, guys. Okay, that's also one of the paraneoplastic syndrome. Okay, elderly men.
Ophistitonous myoclonus. Dancing eye dancing foot syndrome.
That is,
Isn't it?
you can get dancing eye syndrome in neuroblastoma. Yashasvi. Opsoclonus myoclonus is the word that is like classically seen in neuroblastoma. In cerebellar ataxia, which you can get because of paraneoplastic syndrome, you can get a similar manifestations, but that would be like more like ataxia and all those things. Okay. All right. Okay. Okay, elderly patient is coming with progressive. This is very good question. Okay, elderly patient is coming with progressive pain in the right shoulder, and there is right shoulder pain and there is right arm pain as well. He has taken analgesics without any like good relief. There is numbness in his right forearm, which is extending up to the tips of the fourth and the fifth finger, and he's having non-productive cough, streaks of blood, and he's ex-smoker. What do you think this patient is having? Cough, non-productive cough, sometimes with blood. He's ex-smoker, pain in the right arm, numbness in the fourth and fifth finger. What do you think this patient is having? Squamous cell carcinoma is one of the answer here.
And
Or no?
tumor.
Very good, Meet. This is Pancoast tumor. Okay. Why is he having pain along the arm and the shoulder? Because of invasion of
Brachial plexus.
brachial plexus. This is Pancoast tumor which has invaded the brachial plexus, especially the lower trunk of brachial plexus. If you involve the lower trunk of brachial plexus, you might have in like numbness in the fourth and the fifth finger. Okay, so that has invaded the lower trunk of the brachial plexus, and that's why this patient is having weight loss and hemoptysis and cough and pain on the arm and the forearm. Okay, this is Pancoast tumor. If it invades the sympathetic chain, you can get what?
Horner syndrome. Ipsilateral.
Ipsilateral Horner syndrome. Excellent, very good. This is also called as superior sulcus tumor. Pancoast tumor is also called as superior sulcus tumor, and if you at all involve the sympathetic chain, you can get Horner syndrome. Perfect. A 52-year-old man is coming to you with recent onset headaches and dyspnea. He's having persistent dry cough. Okay, dry cough, headache, dyspnea. On examination, there is symmetrical facial swelling. There is conjunctival edema. I'm sorry, there's like construction thing going on the back. There is conjunctival edema, symmetrical facial swelling. Pupils are equal, round, and reactive to light. Pupils are normal. There are dilated veins noted over the neck and the upper trunk. What is the most likely cause of the patient's condition? What's your diagnosis?
Superior venacular obstruction.
My goodness, this is excellent. So you can block your superior vena cava. Because of that, you can have symmetrical facial swelling. Okay, symmetrical facial swelling, symmetrical facial puffiness, your puffiness, conjunctival edema, and this can be some lymphoma of your thorax. Okay, so that lymphoma is obstructing your superior vena cava. As a result of that, you are having all those things. Okay, headache and all those things. So this is SVC syndrome. If I say only just one half of the face and just one arm is involved, then your diagnosis is that has invaded what structure?
Brachiocephalic.
Very good. That's brachiocephalic trunk. So any mediastinal mass can invade the superior vena cava, and when you invade the superior vena cava, your entire face, like there'll be symmetrical swelling of your entire face, conjunctival edema, redness, and when you press your trunk with your fingers, there'll be blanching because of all those redness, and you also see a lot of petechiae everywhere. Okay, and of course you see arm edema also. All right, so that's your lung cancer module. Let's move on. A 67-year-old male is coming to you with worsening shortness of breath. He's having, this is an excellent question. He's having hypoxia with exertion. He is a smoker and he worked for 30 years as a nickel miner. So he's a smoker as well. He's a nickel miner as well. The autopsy is showing bronchi with thickened bronchial walls. Bronchi with thickened bronchial walls. There is inflammatory infiltrates. The mucous glands are enlarged. There is patchy squamous metaplasia of the bronchial mucosa. Okay, which factor was likely the greatest contributor to the patient's pathological finding? He's a smoker. He's a nickel miner, and the biopsy is showing mucous gland enlargement, squamous metaplasia, and thickening of the bronchial mucosa. Okay, is this finding because of the occupation, or is this finding because of the behavioral change?
Behavioral due to
Behavior.
smoking.
Very good. Why do you think this is not occupational? Okay, what's your diagnosis? Yes.
Chronic bronchitis.
Very good. This is chronic bronchitis. Very good. This is chronic bronchitis because of smoking. Okay, so smoking has caused squamous metaplasia, and as a result of that, you have this. Okay, so what happens to the Reed's index in chronic bronchitis?
Increase.
Reed's index increase because of increase in what?
Increasing
Lot of increase in mucosal.
hypertrophy of the gland. Hypertrophy of
Perfect.
mucus secreting gland. Yes.
Perfect. Because of the hypertrophy of the mucus secreting glands, you get lot of mucosal glands hyperplasia, and you can also get squamous cell metaplasia because of the smoking. Okay, so this is a behavioral change. Nickel can cause nickel is a carcinogen as well, but this is specifically leading you towards behavioral change. As this has shown, there is mucosal gland enlargement, there is squamous metaplasia, and also there is thickening of the bronchial wall. This is very, very important finding of because of the smoking. Okay,
And nickel can cause contact dermatitis, right?
nickel can cause contact dermatitis, but nickel is a carcinogen also. Okay, nickel is a carcinogen as well. We also saw one cancer because of exposure of one of the specific metal which can give you angiosarcoma. What was that? Angiosarcoma was because of exposure to what?
Benzene. No.
Huh? That was also starting from, like, let's say that was starting from arsenic. Angiosarcoma is because of arsenic, and that's actually endothelial cell tumor. Okay, perfect. So 40-year-old male is coming with progressive dyspnea. On examination, there is prolonged expiratory phase without wheezing or ronchi. CT scan is showing bilateral lower lobe predominant emphysema. Further testing reveals that the patient has protease inhibitor deficiency, okay, which has led to increased elastin fiber breakdown. Elastin fibers within the alveolar wall normally allow the lung to stretch during the active inspiration and recoil during passive expiration, blah, blah, blah. Now, tell me, what do you get because of protease inhibitor deficiency?
Pan-acinar emphysema.
Pan-acinar emphysema. Because of alpha-1 antitrypsin deficiency, you can get pan-acinar emphysema predominantly in which lobe of the lungs?
Lower lobe.
lower lobes.
Lower lobe of the lung. Perfect. So alpha 1 antitrypsin is normally produced by what organ in your body?
Liver.
Liver.
Perfect. And that inactivates which enzyme? Elastase. Perfect. So alpha 1 antitrypsin wants to inactivate elastase, and elastase is normally produced by
Neutrophils.
neutrophils. Perfect. So this is your entire scenario. So alpha 1 antitrypsin produced by liver normally inactivates elastase, which is produced by neutrophils. And if you don't have enough alpha 1 antitrypsin, your elastase will just play around and digest all the elastic tissue, predominantly in the lower lobe of the lung, because neutrophils can go to the place where there is rich blood supply. And if you know the VQ ratio of the lungs, the lower lobe of the lung receive enough of perfusion. That's why elastase predominantly damage the lower lobe of the lung. But anyways, we studied about collagen tissues, and we studied about elastic tissues in biochemistry as well. So elastic tissue and collagen both has their specific strengths, okay? And elastic tissue has a specific thing which allows them to stretch. Now they are asking what contributes to the elasticity to this elastin. There is we studied about two structures. One is like stretched form, and one other is the normal form. And in between there are like cross links between two fibrils of the elastin. What is doing this cross linking in the elastin tissue or in the collagen? Who does the cross linking? Who does the cross linking? So this is the normal and this is the stretched form. So the stretching of this elastic tissue is happening because of the cross linking. And what enzyme does the cross linking? Cross linking is not done by vitamin C. Vitamin C does proline and lysine hydroxylation. Cross linking is done by lysyl what?
Oxide.
Glycol or something.
Lysyl oxidase. Perfect. And that is what dependent enzyme, what cofactor is needed in lysyl oxidase? Huh?
Nothing.
What? Is it vitamin C? Does lysyl oxidase needs vitamin C?
Yes.
Yes, collagen. Yeah.
No, it needs copper. Vitamin C is like important for proline and lysine hydroxylation. Lysyl oxidase needs copper. Okay, so lysyl oxidase does the cross-linking. That important cofactor for this enzyme is copper, and proline and lysine hydroxylation needs vitamin C. Okay, perfect. All right, let's move on. So this is cross-linking because of lysyl oxidase. That's a copper-dependent enzyme. A young girl is coming with because of shortness of breath and chest tightness for the past 2 hours. On examination, there is diffuse wheezing. The bedside spirometry shows airflow rate that is significantly lower than expected. Okay, that's what people should do as the bedside spirometry. Okay, you check the bedside spirometry and you can immediately know like what's going on with the patient. Treatment with inhaled medication is begun. Okay, and repeat evaluation several minutes later shows increase in the airflow rate. The administered medication is most likely doing what? First of all, tell me, young girl, shortness of breath, lot of wheezing, and there is decreased expiratory flow rate. What's your diagnosis? What's your diagnosis of this young girl? Interesting. What if a young girl is coming with? What physical exam finding would you expect in restrictive lung disease meet? What physical exam finding would you expect in a restrictive lung disease? Here, the physical exam is showing diffuse wheezing. What's your diagnosis? Many people have already got the answer. Huh? This is asthma. There is diffuse wheezing. Wherever you put your stethoscope, if you hear diffuse wheezing, that's like whistling sound while the patient expires. That is asthma, diffuse wheezing. In restrictive lung disease, let's say if the patient is having fibrosis, you would expect crackles, fine inspiratory crackles. And wheezes are something which you see when there is a lot of bronchoconstriction and patient try to expire through the narrow airway. That is wheezing. Okay. So this is asthma. Is it okay, Meet?
Yes.
Okay. Now in asthma, let's say any patient is coming with diffuse wheezing and you give your first medication. Okay. First drug of choice in asthma patient is what? And this is acute presentation. See, worsening, shortness of breath, chest tightness in the past 2 hours. Exactly as mentioned. This is acute presentation, again pointing towards asthma. Okay, you do an inhaled medication treatment in asthma patient. What is that medication you give immediately if the patient has acute attack of asthma?
Beta agonist.
Beta 2 agonist. Perfect.
Beta 2 agonist.
Beta 2 agonist, like you do bronchodilation, you try to do bronchodilation with the beta 2 agonist, like salbutamol, terbutaline, albuterol. So that will do relaxation of the smooth muscles, relaxation of the bronchial smooth muscles. Okay, I'm giving salbutamol, that is beta 2 agonist, that binds to the beta 2 receptor, intrinsically activates what? GS, GQ, GI. Beta 2 agonist intrinsically will activate which proteins? Come on. G or
Yes.
nothing? That is GS.
G.
Perfect. It is GS. Okay, beta 2 agonist will activate GS, even beta 1 will activate GS. Okay, both beta 1 and beta 2 agonists will activate GS protein. It will increase, of course, first of all, it will activate adenyl cyclase. It will increase cyclic AMP, and cyclic AMP will activate what? Protein kinase? A. Protein kinase A will do calcific, protein kinase A will activate the calcium channels, and ultimately ultimately this protein kinase A will do phosphorylations in such a way that there'll be bronchial smooth muscle relaxation. Okay, so here is your diagram. So your cyclic AMP will be activated and it activates protein kinase A, but it will do phosphorylation of the protein in such a way that there'll be smooth muscle relaxation. Okay, so there'll be smooth muscle relaxation after giving beta 2 agonist. Okay, is it okay with everyone? All right.
Yes, sir.
So next question. Elderly women is coming with shortness of breath, cough, productive of thick. This is like both step 1 and step 2. Cough productive of thick green sputum for the past 2 days. Okay. She's having history of COPD and mild dyspnea on exertion at baseline. Now she's having shortness of breath even at rest. So she had increasing shortness of breath. She's having more dyspnea and she's having change in sputum color with the history of COPD. If you have these 4 findings, I would come to a conclusion of diagnosis. Like out of all of you, like were anybody able to make a diagnosis what this patient is having? History of excellent. It was that COPD exacerbation. Excellent. So if you have history of COPD, and now if you have more than 2 out of the 3 I am saying, if you have more cough or change in sputum color, this patient already had change in sputum color and more cough. Okay, if you have more cough or more dyspnea or more shortness of breath. Okay, so Out of these three, if you have just two, we call this as COPD exacerbation. Okay. Now, she has to use more albuterol. Saturation at the room is 91%. On examination, chest X-ray showing diffuse bilateral wheezing, chest X-ray showing hyperinflation. This can be pneumonia if the chest X-ray shows consolidation at some portion of the lung, but this is not pneumonia now. They are asking, okay, if I'm just saying, okay, this is COPD exacerbation, which of the following could be the trigger of this COPD exacerbation? What will you answer? Which of the following would be the trigger of COPD exacerbation? Some viral or bacterial infection. What do you think would you choose out? Like, which is the most common, like upper respiratory tract infection out of viral?
Rhinovirus.
Rhinovirus, coronavirus. Okay. Any of the upper respiratory tract infection could be a trigger for COPD. Okay. Okay. So if I say this is COPD, so even if let's say the patient has upper respiratory tract infection, that could just exacerbate COPD. Okay, in any patient. So those could be the trigger of COPD. Anyways, if a patient comes to you with COPD exacerbation, in step 2, they'll ask you the treatment. Okay. And if I say the patient is having saturation 91% already, would you give additional oxygen to this patient?
Yes.
No.
No. Technically, no. We want the saturation to be maintained at 88 to 92% in COPD patient. The reason why I would not give a lot of oxygen to this patient is because what will happen if you give oxygen?
Carbon dioxide retention.
Yes, if you give oxygen, their respiratory drive will become low and they will develop a lot of hypercapnia because of VQ mismatch and loss of respiratory drive. Okay. So if you give a lot of oxygen to the patient having COPD, if you do give a lot of oxygen in the patient having COPD, they will decrease their respiratory drive. And because of oxygen, see, pulmonary system has pulmonary hypoxic vasoconstriction. If you give oxygen, everything will be messed up when you give oxygen. The area which should have less perfusion will get more perfusion. So because of a lot of VQ mismatch, you like tend to retain more carbon dioxide, and also you lose your respiratory drive when you give oxygen. So when this happens, you'll have retention of carbon dioxide, and this patient will have hypercapnia if you give a lot of oxygen. So give only oxygen when your saturation is less than 88%. That's number one. Will oxygen improve mortality in patients of COPD exacerbation? The answer is definitely yes, if the saturation is less than 88%. So oxygen is one of the treatment. Second line, would you give antibiotics to the patient? If I say, okay, it's caused by, let's say, some infection. Okay, let's say in this patient only, would you give antibiotics?
If it is due to the virus, then no.
Yeah, if we definitely know that this is due to virus, then we don't give antibiotics. But it's like difficult to say because it's because of viral or bacterial, because most of the time we don't do like, okay, we want to check for rhinovirus infection, or you send the patient for ELISA or RT-PCR. We would just say, okay, for the safer side, because we don't know 50% of the time it can be viral, it can be bacterial. So just give antibiotics on the safer side. And the studies have shown it will improve the mortality. That's why we are giving antibiotics. Of course, third thing, would you give bronchodilators to this patient of COPD exacerbation?
Yes.
Yes, that improves mortality. And fourth and the final was steroids. Would you give steroids in the patient of COPD exacerbation?
No.
Yes.
Yeah. Yes.
Yes, it does improve mortality. The studies have repeatedly shown that the steroids would improve mortality in patients of COPD exacerbation. Only for short period of time, do not continue the steroids. Okay, only for very, very short duration. So these are the four important modality of the treatment in COPD exacerbation. Oxygen, you want?
Steroid is immunosuppressive, so then more chances of viral attack can be there.
You are definitely correct. Udvas, and that's why we don't want to give steroids for a longer term. If you continue for steroids for longer term, it's a problem again. We are only giving steroids for very, very short term, just in order to suppress our own immune system attacking ourselves. Like all like neutrophils coming up here, all macrophages coming here, which are like worsening the inflammatory cycles. We want to suppress that. That's the reason we are giving steroids. At the top, we also want like enough bronchodilation to happen. So steroids also have like some permissive role in bronchodilation. In short, I want to stop the vicious cycle of the inflammation happening in your bronchioles, in your airway. That's the reason we are giving steroids in patient of COPD exacerbation. Is it okay, Udvas?
Yes.
And
Why
in
the-
any
Why the green sputum is there? Why the sputum is green?
see, whenever you see green sputum, do not always think about Pseudomonas. Okay, so sputum can be a lot of yellow colored, green colored. This color changes because of your own epithelium, which has like degraded, and like all those debris can make up green color, or there is possibly some infection which has caused the green color. So it can be your sputum mixed with some foreign particles, mixed with your degraded epithelium or decaying epithelium, your own respiratory epithelium, and all those mixed thing is like giving some color. It can be because of bacterial infection, it cannot be because of that. So do not always think green color means Pseudomonas. The sputum color can be any. It can be or cannot be because of Pseudomonas infection. That was like your step 2 question. There was like one question about yellow colored sputum. That does not mean it is bacterial infection. Yellow colored can be because of your own pus cell, your own WBCs as well. Okay, because your WBCs are doing n number of reactive oxygen radical damage, so that can change the color of the sputum. And that's why now sputum color is not regarded as a sensitive marker for bacterial infection. It was previously. Now there is no importance of sputum color, no longer importance of sputum color. All right. So that's your, is it okay, Udvas?
Yes, sir.
Okay. Perfect. So this is COPD exacerbation because of rhinoviral infection. It can be because of any, okay? It can be any viral, bacterial, or any air pollution. Anything can exacerbate your COPD. All right. This is how you have to diagnose increased dyspnea or cough or change in sputum color or quantity. This is out of these three. If you have any two, that's a diagnosis of COPD exacerbation. And ABG will of course show hypoxemia and CO2 retention, hypercapnia. So we talked about extensive COPD exacerbation. Okay, next question. Let's say we have a 21-year-old male patient with asthma. He's coming for a follow-up. His asthma symptoms are not adequately controlled with albuterol as needed. So we added one additional therapy at the previous visit. Now, the patient is having some white lesion which can be easily scraped off in the oropharynx. How can you prevent this finding?
Oropharyngeal candidiasis, basically.
Perfect. This is oropharyngeal candidiasis. How can you prevent this in patients of asthma?
Washing the mouth after
Cleaning the spacer.
Using the spacer, or you ask the patient to rinse the mouth, or what did we add as in the previous visit?
inhaled corticosteroids.
Steroids.
Perfect. Inhaled corticosteroids. Perfect. You ask the patient to gargle after the use of inhaled corticosteroids. So these are oropharyngeal candidiasis. You can easily scrape off while you with the Q-tip. What will you think if you cannot easily scrape off? What do you think will about the leukoplakia? Wonderful. All right. Next question. This is blue is the patient, black is the normal patient, the normal population, and you are doing your PFT, lung volumes, and this is the time. You ask the patient to expire rapidly. You ask the patient to expire. What's your diagnosis? This blue patient?
Lung disease.
Excellent. Obstructive lung disease. Okay. This patient was able to expire most of its air in 1 second. Their FEV1 was like normal. And this patient was able to expel only this much of air in 1 second. So your FEV1 is decreased significantly in obstructive lung disease. Okay, very good. And of course, what will happen to the total lung capacity in obstructive lung disease?
High. Increase.
Very good. What about residual volume?
Increase.
Increase.
Perfect. Perfect. So that's obstructive lung disease. Next question. Okay. Elderly man is evaluated for exertional dyspnea. He is having smoking history. Lungs are hyperresonant and there is diffuse wheezing on auscultation. Chest X-ray shows flattened diaphragm with a narrow mediastinum. What do you think is this patient having?
COPD.
Very good. This patient is having COPD, and they are asking in this COPD patient which of the following A, B, C, D, like pulmonary finding will you see? Lung volume pattern. Which one?
B.
B. Excellent. Why?
Residual volume increases and total lung capacity also increase.
Very good, Meet. So total lung capacity has increased and residual volume has also increased. Okay, so this is residual volume, this is vital capacity, and this is your what is this? So this is tidal. What is this? This one. I think that's inspiratory.
What's vital capacity?
IRV.
No, this one. This is like entire FVC, and I think this is tidal volume, and this is your inspiratory reserve volume. And you combine inspiratory reserve volume, tidal volume, and expiratory reserve volume, and you make forced vital capacity. And this is the volume you cannot exhale, so that's residual volume. And this entire thing is total lung capacity. So perfect. If I just go back, so this is, you said obstructive lung disease. What about this one? What is this?
Restrictive lung disease.
This is restrictive lung disease. Perfect. All right. A 36-year-old man is coming with shortness of breath. He reports episodic cough and chest tightness for the past 4 months. Recently, he went on a 2-week vacation in Wisconsin and reports that he had no symptoms during the trip. But when he returned to the home and went back to the chemical manufacturing factory, now he has again started developing the symptoms. On examination, expiration is mildly prolonged and there is scattered wheezing while he is at while he is at the office. And the office spirometry is showing FEV1 by FVC of 82%. Chest radiograph is like showing no abnormalities. What do you think this patient is having? So actually, this question is saying this patient is having episodic cough and chest tightness, but when he went on a vacation, he was normal. When he came back, he started having the symptoms again. He's actually working in a chemical manufacturing company. So what do you think your diagnosis is?
That's that's called on Saturday. What it's a
Saturday holiday
just
syndrome.
forget it.
You are confusing this with nitrates.
Okay, yes.
In nitrates, it can be a possibility that when you come back to the work on Monday, that's called as Monday's disease, you can start having headaches again. That happens with nitrates. That's why we ask the patient to have nitrate-free intervals. But this patient is having cough while at
Allergic
work.
rhinitis.
This is some possibly allergic rhinitis. The patient can have a lot of rhinorrhea. This patient is having episodic cough and chest tightness.
I mean that seasonal one, allergic rhinitis.
Seasonal. So why is he not developing cough when he went for a vacation? Only when he came back. This is what?
Any restrictive lung disease?
This is asthma, but this is occupational asthma. You see, when the patient was uh, at office, his spirometry was nearly normal. Chest X-ray was also normal. Why restrictive lung disease? Means chest X-ray is normal. This is not restrictive lung disease. So FEV1 by FVC ratio is normal. In asthma, since this is an episodic disease, it may be possible your PFT at rest is very, very normal. Okay. So this is occupational asthma. So classic presentation is when the patient comes back to work, the patient has symptoms, and patient goes out for a vacation, he's okay. Okay. Very, very classic of occupational asthma. Probably there are some allergens which he is allergic to at work. Okay. So this is classically occupational asthma. Okay. Extrinsic asthma. All right. 21-year-old man is coming to you with cystic fibrosis for routine follow-up. Patient had multiple hospital admission over the last few years for pulmonary exacerbation. And they are asking what will be their TLC, FEV1 by FVC ratio, FVC, and RV. So cystic fibrosis is what kind of lung disease? Restrictive or obstructive lung disease?
Obstructive.
Obstructive.
Why?
Production of thick mucus.
A lot of production of thick mucus, and with the vicious cycle of infection, you can ultimately get bronchiectasis in the cystic fibrosis as well, right? So
Yes.
bronchiectasis in cystic fibrosis, that's an obstructive lung disease. What will be your TLC?
High.
FEV1 by FVC ratio?
Low.
Perfect. And what about FVC?
Low.
FVC will be low as well, but FEV1 will be very, very, very low as compared to FVC. What about residual volume?
Increase.
Increase.
Increase. Perfect. So that's obstructive lung disease because of bronchiectasis. Okay. Middle-aged man comes with you because of occasional dyspnea that awakens him at the night. The older brother has atopic dermatitis. Vital cells are okay. Let me see. Lung auscultation reveals bilateral normal breath sounds. No wheezing, no crackles. Heart sounds are normal. PFT is showing FEV1 88% of predicted, FEV1 by FVC 84%. Is this normal? DLC of 95, is this normal? Vital cells are, let's consider this okay
Asthma.
as normal. This is asthma. FEV1 by FVC and DLC, everything is normal. Okay. So if the patient comes to you with occasional dyspnea, episodic dyspnea and cough, so probably we are thinking about asthma. But this patient is having all the PFT findings which are normal. So during PFT, what can you give that can provoke asthma? That's what they are asking.
NSAIDs.
I know what you are thinking, Yashasvi. You want to say, okay, you give NSAIDs, you block COX, so that will increase the production of LOX, and you want to increase your leukotriene. That takes time, right?
Yes.
At least 24 hours. NSAID-induced respiratory disease. But what can you do acutely to just test and irritate your bronchi that will provoke bronchoconstriction? Starting from M. Dash challenge test.
Methacholine challenge test.
Methacholine challenge test. Perfect. So that's, you can do methacholine challenge test. So actually that's not done at very, very first place. Okay. If you do that at very, very first place, it's considered as a crime now. So why would you do bronchoconstriction in patients who are already having trouble breathing? It's just like bleeding time. You cannot let the patient bleed continuously. So you do methacholine challenge test only if it is like you have tried everything, is still you cannot diagnose asthma. So it is very, very high possibility when the patient comes to you, his PFT finding will be normal. So if you want to confirm that, do methacholine challenge test, and then later on you can confirm the diagnosis. Okay, so you can do methacholine challenge test. Methacholine, what kind of drug this is? Cholinergic, anticholinergic, what?
Cholinergic.
Methacholine, it is a cholinergic drug. Okay, that's why it does bronchoconstriction. Perfect. Methacholine. Okay. Oh my God. Young girl is coming to you with hemoptysis. She is having severe respiratory distress. I'm summarizing the question. She is having so much of hemoptysis that her vitals become 90/60. Tachycardic. Respiratory rate is 42. She's having copious red blood produced while coughing. During examination, the production of blood becomes so rapid. Despite of aggressive management, the patient ultimately dies. They are asking what's the source of bleeding. I'll give you two options and you have to tell me, is it pulmonary veins or is it bronchial arteries? What's the source of bleeding in this patient? Bronchial artery or pulmonary vein? Okay, out of these two, which is high pressure or low pressure system?
Pulmonary vein.
Vein is high pressure.
Pulmonary vein is high pressure.
Mhm.
For that, you have to know from where the branching is happening actually. So actually, this is your right atrium. You already know this, but this is right atrium, this is right ventricle. Right ventricle gives rise to pulmonary artery. And of course, this is ultimately going to the lungs. But from where the bronchial artery is branching off?
Aorta.
Aorta. The lung has dual blood supply. One is from pulmonary artery and the second one is bronchial artery, and that is actually branching from aorta. Okay, so bronchial artery actually is branching from aorta. Now if I say which is high pressure, bronchial artery or pulmonary vein?
Bronchial artery.
It is bronchial artery because the highest pressure in aorta is 120 mm of Hg. The highest pressure in the right ventricle is just 25. Okay, 25 mm of Hg. So high pressure system is of course bronchial artery. So actually the bleeding is from bronchial artery. Okay, bleeding from hypertrophied bronchial artery. So pulmonary trunk is a low pressure system. Bronchial artery is a high pressure system. Okay, because it is branching off directly from thoracic aorta and some of the intercostal bronchial trunk as well. But this pulmonary veins are directly branching from the pulmonary trunk. So that's a low pressure system. So that was a little bit anatomy question. A 35-year-old man who is an avid hiker comes with shortness of breath. He was initially having shortness of breath, but now is like even occurring while he's just walking. So progressive shortness of breath in young patient. He's having mild wheezing, sputum production. He takes antihistaminics without any improvement. He had some history of smoking. His father died from lung and liver disease. There is a family history of lung and the liver disease. Now the patient is also having shortness of breath. The spirometry is showing decreased FEV1, decreased FVC, and decreased FEV1 by FVC ratio. What's your diagnosis?
Pan-acinar emphysema.
Pan-acinar emphysema. What's your diagnosis?
Alpha-1 antitrypsin deficiency.
Alpha-1 antitrypsin deficiency. Mode of inheritance?
Codominant.
Codominant. Excellent. Codominant alpha-1 antitrypsin deficiency, because that can involve both lungs and the liver. Okay, and liver can also progress to cirrhosis. Lung can give you pan-acinar emphysema. If you do the biopsy of liver, what stain it will be positive, because all the alpha-1 antitrypsin are accumulated inside. It's not able to secrete outside because of misfolding. That will be positive for alpha-1 antitrypsin is positive for pass. It is pass positive. So liver biopsy will be pass positive because of the misfolded proteins are accumulated inside the cells. Okay. And lungs will have pan-acinar emphysema as well. So that's alpha-1 antitrypsin that has family history, autosomal co-dominant. Okay. So that's pan-acinar emphysema. See, this patient, young patient with emphysema, even with or without smoking history, you have to think about alpha-1 antitrypsin deficiency. Okay. You have to definitely ask this patient to stop smoking. But if it all the patient is not smoking, you have to ask the patient to avoid the second-hand smoke as well. That's very, very important. Okay. Researchers developed a novel agent to treat extrinsic asthma. In a clinical trial, the patient with moderate to severe asthma treated with this medication experienced fewer exacerbation, blah, blah, blah. They also found to have lower levels of serum IgE even after exposure to triggering allergens. Analysis of genomic DNA shows reduced IgE isotype switching in activated B lymphocytes. This new medication most likely inhibits which cytokine that can prevent class switching from IgM to IgE? Your answer is
IL-6, 5.
L2.
no. Which
IL-4.
Yes, interleukin 4. Interleukin 4 does class switching to IgE. What interleukin does class switching to IgA?
5.
5. What's the another function of interleukin 5?
Eosinophil recruitment.
Yes, eosinophilic recruitment. Okay, so this scientist actually wants to form monoclonal antibodies against interleukin 4 so that they have less class switching from IgM to IgE. We also have some monoclonal antibodies against interleukin 5, which can prevent the eosinophilic recruitment. Okay, so these are some experimental drugs. So remember interleukin 4 for IgE class switching. Remember interleukin 5 as an eosinophilic chemotactic factor. So we want to target interleukin 4 here. Okay, we want to target interleukin 4, which can prevent class switching to IgE. And interleukin 5 is for eosinophilic recruitment. Remember here, interleukin 5 for eosinophilic recruitment, interleukin 4 for IgE. Very, very important. Okay. A 44-year-old woman comes with episodic shortness of breath and cough. Pulse oximetry showing 96%. Lung examination and chest X-ray are normal. Spirometry shows that FEV1 is 71% of predicted value. Sputum analysis is showing predominant eosinophils. Exposure to what most likely closely is associated with this patient's symptoms? I mean, this is a woman who is having less FEV1, chest X-ray is normal, lung examination normal, pulse oximetry is normal, but sometimes she has episodic shortness of breath and cough. What's your diagnosis? And of course, it is showing a lot of eosinophils.
Okay,
Diagnosis?
suppression of asthma.
This is asthma. What were you saying, Udvas? This is asthma, right? This is asthma. So you can, if the option has any exposure to any allergen, that's your answer. It can be animal dander, it can be dust mite, house dust mites, cockroaches, pollens, molds, cigarette smokes, air pollution, perfumes. That's why whenever you go for rotations in any hospitals, they'll have those instruction written. Never put a lot of strong perfumes because some patients may have asthma and you might precipitate asthma in those patients. So beta blockers, because beta blockers can prevent beta-2 mediated bronchodilations. Aspirin, as we talked about, it can inhibit COX, it can do the LOX overproduction. GERD. There was one question that if a patient is having GERD and at the top patient is having asthma, sometimes micro aspiration can precipitate asthma. So in those patients, if you give PPI, that can prevent triggers of asthma. So if the patient has asthma and GERD, you would do everything for asthma. Still the patient is having cough. You think about GERD. Is the patient having GERD symptoms? If you keep the patient on PPI, that can prevent the exacerbation. Okay, very, very important, because micro aspirations of the acid can precipitate asthma. That's your step 2 concept. But cold and dry air, okay, that's your NBME question. Never ever expose the patient to NBME LARAS. Not NBME, cold and dry air. Okay, so that's your asthma. Okay, spot diagnosis. What is this chest X-ray showing? Spot diagnosis,
Emphysema.
emphysema or COPD. Okay, long tubular heart, flattened diaphragm, long lungs. I mean, large lungs because of large TLC. Okay, I think that's your question. So COPD, what changes you would expect? So high residual volume and high total lung capacity. Okay, so that's your COPD. I think that's all about today's session. Perfect. Do we have any questions before we sign off about this session? All set?
Yes, sir.
All right. Let's stop this. Thank you, everyone.